Welcome everyone to today's webinar. I am Tracy Cook with Sachs Healthcare Communications, and I'll be your webinar producer for today's webinar on new clinical evidence available for the treatment of positional OSA. Our moderator for today is Steve Kovlin. He is currently the Clinical and Market Access Lead for the NightBalance product at Philips Respironics. He has a PhD from the University of Liverpool, which is focused on the cardiovascular and metabolic consequences of OSA. He has over a 15-year career in industry, and he has managed over 100 international industry-led studies and collaborated on numerous investigator-initiated studies. He has published over 10 articles in peer-reviewed journals and presented at numerous national and international medical conferences. Steve, welcome.
Thank you, Tracy, for that very kind introduction. And thank you, Philips, for providing support for this educational activity. The title of today's webinar is New Clinical Evidence Available for the Treatment of Positional Obstructive Sleep Apnea. We are very fortunate to have two extremely qualified speakers today presenting on this very important and timely topic, Dr. Aberlock and Ms. Elizabeth King. Dr. Aberlock is a neurologist and sleep specialist at Brian Aberlock, LLC in Paoli, Pennsylvania. His practice focuses on outpatients. Early on in his medical training, Dr. Aberlock wanted to practice sleep medicine, and since sleep is a brain function, Dr. Aberlock chose neurology as the pathway to sleep. Dr. Aberlock completed his sleep medicine fellowship at Harvard Medical School. There, he created a protocol to assess the effect of sleep deprivation upon learning. He has written several articles published in peer-reviewed journals and has presented at many national and international conferences. Our second speaker is Elizabeth King. Ms. King is a certified nurse practitioner at Brian Aberlock, LLC in Paoli, Pennsylvania. Prior to joining Dr. Aberlock, Ms. King worked as a registered nurse at Christiana Care in Wilmington, Delaware. In 2013, she received the Delaware Nurses Association Top Inpatient Nurse Award and was a finalist for the Delaware Excellence in Nursing Practice Award. She graduated from University of Pennsylvania's Adult Gerontology Primary Care Nurse Practitioner Program. Upon graduation, she was honored by the Ralston Center for Gerontology Nursing Excellence. She works closely with Dr. Aberlock to manage insomnia and sleep apnea. Dr. Aberlock has provided the following disclosures for his talk. He's been involved as an investigator in a study that included the NightBalance device called the Positive trial, which was funded by Philips Respironics. Ms. King also reports being a participant in that study also. In order to obtain continuing education credits, a link will be available for physicians at the conclusion of the webinar. This activity is jointly provided by Synaptive and Sachs Healthcare Communications, and the accreditation statement can be seen on the slide. Support for this educational activity has been provided by Philips Respironics. For nurses and respiratory therapists, continuing educational activity is approved for 1 contact hour. And again, the accreditation statement can be read from the slide. Without further delay, I'm now going to hand over to Dr. Aberlock to present today's first webinar. Dr. Aberlock, the floor is yours.
Thank you, Steve, for that kind introduction, and thank you to everyone who's watching this webinar. I appreciate your time. Liz King and I were working with Philips on the development of the NightBalance device. We've had experience with patients who have positional sleep apnea. We've treated positional sleep apnea using this device. In sleep apnea, in the treatment of sleep apnea, we have very few options in general. It's exciting to have a new option, a new method of treating patients with this extraordinarily common disorder. It is also exciting to be able to offer people something that is simple, that is effective, and that is non-invasive. The learning objectives of today's presentation, we will identify new findings in the positive study. We will describe how positional therapy fits in the treatment of positional sleep apnea. We will recognize the value of the patient portal for both the physician and the patient accessing data via a smartphone. In terms of my presentation outline, there will be a discussion of obstructive sleep apnea and positional obstructive sleep apnea. There will be a review of the positive study. There will be a discussion of the NightBalance device. Elizabeth and I will go through some case studies of the treatment of positional sleep apnea. In terms of acronyms in this case, POSA will stand for positional obstructive sleep apnea. Here's how I think about the pathophysiology of obstructive sleep apnea. You can imagine the airway as a tube going from your nose and mouth to your lungs. It is surrounded by soft tissue and muscle. When you are awake, that muscle is taut. It holds the airway open. When you fall asleep, the muscle relaxes and the airway begins to shrink down. When the airway partially shrinks down, airflow through becomes turbulent. Structures in the throat vibrate. That is snoring. When the airway totally closes, you cannot breathe through it. It's like you're choking. When the airway closes, lungs, blood, heart, brain cannot get oxygen. Brain sends a signal to muscles around the throat, causing them to tense. Airway opens, spike in blood pressure, spike in pulse. Short-term sleep apnea causes fragmentation of sleep and sleepiness during the day. Long-term sleep apnea increases risk of heart attack, stroke, and likely of Alzheimer's disease. I like this particular illustration because it shows us what happens when we're sleeping in the supine position, when we're sleeping in the supine position on our backs. The tongue and the soft palate collapse into the back of the throat. In most patients, breathing is more impaired in the supine position than in the non-supine position. In terms of patients who are good candidates for positional sleep apnea, we simply see an amplification of this effect, where breathing is much more impaired in the supine position than in the non-supine positions. In terms of the epidemiology of sleep apnea, it is overwhelmingly common. Depending on how one defines sleep apnea, depending on what metrics one uses, roughly 10 to 25% of the population of the United States has some degree of sleep apnea. Obesity is the single most significant risk factor for sleep apnea. The heavier an individual, the higher the risk of sleep apnea, the higher the body mass index, the higher the risk of sleep apnea. I think that most physicians understand that obesity is a risk factor for sleep apnea. What's important about understanding obesity is that while obesity is a risk factor, it is not the only risk factor for sleep apnea, and lack of obesity should not blind us to patients who may still have sleep apnea. Age is a substantial risk factor. In particular, as women go through menopause, their risk of sleep apnea increases significantly. Type 2 diabetes and high blood pressure increase risk of sleep apnea. There's a close correlation in the co-occurrence of sleep apnea and type 2 diabetes and hypertension. Not only is there a correlation, but in some cases, sleep apnea may contribute to the development of high blood pressure. It may modestly contribute to difficulty with blood sugar control in type 2 diabetes. A thick neck is a substantial risk factor that to some extent goes along with obesity. All of us store some fat in the neck, in fat pads around the airway. Those fat pads push out and cause the neck to be thick. They also push in and constrict the airway and make the airway more collapsible. Retrognathia, or a small, or what we think of as almost a receding jaw, is a risk factor for sleep apnea. Retrognathia pushes all of the anterior structures of the tongue and the soft palate backward into the throat. A crowded airway is a risk factor as well. I think that while crowding of the airway can help us predict sleep apnea to some extent, there's some variation in how people assess whether an airway is crowded or not. I find it to be modestly helpful. I find it to be very helpful in young people with large tonsils. Otherwise, it's hard to know whether a crowded airway, at least in my clinical practice, is a meaningful clinical predictor. Male sex clearly increases risk of sleep apnea. Why should we treat sleep apnea? There are benefits to cardiovascular health. Treatment of sleep apnea reduces risk of stroke and heart disease. I think the data are particularly compelling in atrial fibrillation and congestive heart failure. Patients who have sleep apnea are at higher risk of developing atrial fibrillation and congestive heart failure. Patients who have atrial fibrillation and sleep apnea, when they go through treatment of their sleep apnea, tend to do better. There's good data that patients who have gone through an ablation or cardioversion as treatment for atrial fibrillation and who have gone into normal sinus rhythm can stay in normal sinus rhythm more reliably when sleep apnea is treated. I think there's also reasonable data that sleep apnea treatment helps with stroke recovery and that it helps prevent recurrent stroke. There are benefits to memory of sleep apnea as well. As many of you may know, amyloid beta is a protein that's involved in the development of Alzheimer's disease. All of our brains generate amyloid beta during the day. At night, if a brain is healthy and breathing is normal, that amyloid beta is cleared. However, in patients who have sleep apnea, the clearance of amyloid beta is impaired. And so the amyloid beta continues to accumulate. We see sleep apnea as a risk factor for Alzheimer's disease, and there is ongoing research with the hope that treatment of sleep apnea can reduce risk of the development of Alzheimer's disease. I think there are more subtle benefits to memory in people other than just the prevention of Alzheimer's disease. One of the great functions of sleep is memory consolidation. If I teach you a pattern of finger tapping today, and I give you a chance to practice, and then I let you sleep, you'll actually know that pattern of finger tapping better tomorrow than you did today. And the reason is that you had a chance to consolidate that memory during sleep. It turns out that in patients who have sleep apnea, this memory consolidation is likely impaired. When I talk to patients about this, I say all of us, as we age, may struggle a little bit more to learn new skills. I think that the treatment of sleep apnea may be something that helps us pick up these new skills in a more natural way over time. Treatment of sleep apnea benefits quality of life. It helps patients feel more refreshed in the morning. There are so many patients who come to me with their primary issue just being that they're not refreshed in the morning. It's quite disturbing. The other benefits to quality of life are that people sleep more solidly and can feel more wakeful during the day. There's also a benefit to the quality of life of bed partners. Many patients come because snoring is disruptive to a bed partner, and anything we do to treat sleep apnea should help snoring and should therefore improve the quality of sleep of bed partners. When I see young, sleepy patients, I think of their greatest risk to life and limb as being drowsy driving. The CDC tells us that up to 6,000 people die every year from drowsy driving. And I think many of those people probably fall asleep because of untreated sleep apnea. So treating sleep apnea doesn't just help our patients, it helps other people on the road. Our current options for treating sleep apnea include the following: CPAP, continuous positive airway pressure, machine tube interface. The device generates pressure and holds the airway open using pressure. CPAP is effective for many of our patients. It is not for everybody, though. It is not tolerated by everybody. I will say it is the current gold standard of treatment in the field of sleep for sleep apnea. And one of the things about this particular study that I'm going to describe to you is that we used CPAP as a control group. We used CPAP as our primary control, and we'll talk more about how positional therapy compares. An oral appliance is like a retainer that fits over the top and bottom teeth and pushes the lower jaw forward. It opens the airway behind the tongue. The oral appliance generally provides some benefit to breathing during sleep. It rarely resolves sleep apnea entirely. At least in the United States, the process of getting an oral appliance typically involves going to a dentist. There's a good deal of time involved. Going to a dentist for an oral appliance can also be expensive depending on the area and whether insurance will cover the oral appliance. There are surgeries for sleep apnea. There's upper airway surgery, which has a mixed record. There are certainly patients who can benefit from removal of upper airway structures. However, it's hard to know these patients ahead of time, and many patients, when I see them, have already had upper airway surgery and still have sleep apnea. Neurostimulator placement. So this is the Inspire device that fits under the skin and sends a lead to cranial nerve 12, which stimulates the tongue and causes the tongue to protrude during breathing in during sleep. This has helped some of our patients. Again, this is not a treatment for everyone, nor is this treatment as effective as sleep apnea in many cases. I've recommended bariatric surgery to many of my patients. Bariatric surgery involves a substantial amount of weight loss. It's one of the few evidence-based methodologies of weight loss that we have available to us. Again, bariatric surgery is not for everyone. In most cases, there will be some benefit to sleep apnea. Maxillomandibular advancement. Here, the top and the bottom jaw are broken and the entire face is advanced forward. It is a difficult surgery to recover from. It is quite effective, though. And today, we're going to talk much more about positional therapy for sleep apnea. The state of positional therapy before NightBalance involved first a tennis ball method, where we say to patients, put a tennis ball in the back of your t-shirt or cut a tennis ball in half and put it in the back of your t-shirt. The issue with this was that patients wouldn't stick with it. There was a paper published in 2009 in the Journal of Clinical Sleep Medicine, essentially saying that almost nobody stuck with the tennis ball method after a year. People can use bumper devices. The bumper devices are a little bit better than a tennis ball. Essentially, there's a strap and a soft bumper in the back that's worn during sleep. These are still uncomfortable. These still wake people up when they're trying to sleep. There were no high-quality studies of any positional therapy until NightBalance was studied. So here I'm going to discuss the paper that we were involved with that was published in the Journal of Clinical Sleep Medicine in 2019, NightBalance Sleep Position Treatment Device versus Auto-Adjusting Positive Airway Pressure for treatment of positional obstructive sleep apnea. Here's what the NightBalance device is. It's a soft strap that's worn around the torso, typically around the chest. There's a case, there's a sensor device. The sensor device is inserted into that little zippered compartment that you can see, and there's a docking station. Essentially what the NightBalance does is over the course of 9 days, it learns how patients sleep, it learns what positions patients sleep in. Gradually, it introduces vibration when patients are in the supine position. So when patients are sleeping on their back over time, it introduces more and more vibration, and that vibration causes patients to turn from the supine position, from the position where they're sleeping on their back, to a position where they're sleeping on their side. And this is what the NightBalance device looks like in person. It is quite a simple thing to wear. It's a simple thing to put on. It is external compared to so many treatments that we're accustomed to in medicine. One of the things that's intriguing about this is that the NightBalance device really provides a greater freedom of motion than almost anything else on the market for the treatment of positional sleep apnea. To take a step back, all of us rotate during sleep. Even my patients who tell me, Dr. Abeluk, I really, I never sleep on my back. When we do a study, we often see at least a little bit of supine sleep. And there are reasons for this. So I think that, all of our bodies rotate because we want to take pressure off the joints. We want to take pressure, off certain areas of the skin. We want to take pressure off our bones and our backs. In most cases, so if you're wearing a tennis ball and you're sleeping on your side, you can turn onto your front, but you can't turn onto your back. Potentially, you can turn onto your other side from your front, but again, it becomes difficult to turn directly from side to back. And the NightBalance device more than any of these other devices, allows people to turn in a fairly natural way. If you're on your right side, you can turn onto your back or onto your stomach. The NightBalance device will allow you to do either. However, if you're on your back, it will vibrate and cause you to turn back onto your side. And I think part of the reason that people tolerate this device so well is that it allows this freedom of motion, and it's not a bumper or obstacle positioned at the back that wakes you up when you turn onto your back. We looked at two groups of eligible patients, both with positional obstructive sleep apnea. The first group had moderate to severe positional obstructive sleep apnea. Positional obstructive sleep apnea, you'll see sometimes as POSA. Severity, AHI, apnea-hypopnea index. This was defined using our standard AASM criteria, where hypopneas were defined as either narrowing of the airway leading to brain arousal or narrowing of the airway leading to a 3% oxygen desaturation. Apnea means a complete closure of the airway. Hypopnea means narrowing of the airway, associated either with the brain awakening or with this 3% desaturation. Index means that these events are indexed to 1 hour. So apnea-hypopnea index you can think of as the number of pauses in breathing or interruptions in breathing per hour. In one group, it's greater than 15. In this moderate to severe group, they could have any level of sleepiness. In terms of positionality, supine AHI had to be at least twice non-supine AHI, and the non-supine severity had to be quite mild with an AHI less than 10. We were also interested in patients with mild positional obstructive sleep apnea with sleepiness who had AHIs of 10 to 15. ESS stands for Epworth Sleepiness Score. An Epworth Sleepiness Score is one way of assessing sleepiness. In research, we're using this as our primary proxy for patients' level of sleepiness. Positionality, again, patients had to have at least twice as much apnea in the supine position than in the non-supine position. In terms of non-supine severity, these patients had to have a non-supine AHI less than 5. So here's how we started. So this is a randomized controlled trial. A randomized controlled trial is the gold standard of evidence in medicine. 187 patients in whom we had some suspicion of positional sleep apnea were assessed. Roughly 117 were randomized. So the majority of patients who were assessed for this trial were randomized into the trial. Patients either received APAP, which stands for automatically adjusting positive airway pressure, first, or they received sleep position therapy first. So again, APAP, automatically adjusting positive airway pressure, is typically the way that we deliver positive airway pressure. It's similar to CPAP, continuous positive airway pressure. APAP just describes pressure that varies across the course of the night in response to patient needs. I would think of this once again as the gold standard of treatment in sleep medicine at this point. So if a patient got positive airway pressure first, the patient would use positive airway pressure for 6 weeks. We would ask several questions. We'd look at compliance. We'd look at satisfaction. And then at the end of 6 weeks, the patient would get an overnight in-lab study with automatically adjusting positive airway pressure in place. After that, the patient would transition to sleep position therapy, SPT, sleep position therapy, also known in this case as NightBalance. If the patient received SPT or sleep position therapy first, the patient would then go through 6 weeks of sleep position therapy, would ask a whole bunch of questions. The patient would get a study with sleep position therapy at the end of 6 weeks in the lab, and we'd look at how well did sleep position therapy work. After 6 weeks, these patients would then go to automatically adjusting positive airway pressure. They'd use AutoPAP for 6 weeks. And at the end of 6 weeks, they would receive another study in the lab with automatically adjusting positive airway pressure. So we could compare studies within each patient on SPT versus AutoPAP. The great majority of patients who were randomized actually completed the study. 117 patients were randomized and 110 completed the study. Here we have a graph that shows us the relative effectiveness of a couple different treatments. So AHI, events per hour, is on the y-axis. Sleep, non-REM sleep, REM sleep, or REM sleep is also known as dream sleep, are on the x-axis here. Here in the white is patients at baseline with this oval representing a mean. Here are patients with the SPT device in blue, and here are patients with the AutoPAP device in gray. You can see that compared to baseline in sleep overall, in non-REM sleep, and in REM sleep, patients using SPT were statistically significantly better treated than at baseline. Patients using positive airway pressure were also better treated than at baseline, and patients using positive airway pressure had AHIs that were lower than those patients with using the SPT device. So the question is, how large is that difference? And it turns out the difference is actually quite small between SPT and APAP. SPT versus AutoPAP, the difference is somewhere between 2 and 5, and the difference is fairly constant over severity of sleep apnea. So no matter how severe your sleep apnea, it was fairly similarly treated on SPT versus AutoPAP. Our primary endpoint in this case was, does SPT treat sleep apnea in a non-inferior way compared to CPAP? And we define non-inferiority as SPT leading to no more than 5 more events per hour compared to positive airway pressure. So we could see a few more events per hour on SPT, and based on that metric of 5, say, okay, this is still similar to CPAP, it is non-inferior. The reason why I think that non-inferiority model is valid in this case is that patients clearly used the SPT, our positional therapy, more than they used AutoPAP in our trial. And this difference is substantial. It's statistically significant. You can see that it's about a 60-minute difference. It's about a 1-hour difference per night in SPT use versus automatically adjusting positive airway pressure. The majority of patients felt that SPT was easier to use. The great majority of patients said that the positional device was easier to adjust to, and the great majority of patients, roughly 82%, said that positional treatment was more comfortable than AutoPAP. So I'm going to hand this over to my colleague, Liz. Liz is going to present a couple cases, and I'm going to provide some feedback on patients' presentations. Thank you, Liz.
So our first case study is a 57-year-old female. She typically is getting into bed between 10 and 11 p.m. and exiting bed in the morning between 5:30 and 6 a.m. We saw her initially in consultation for snoring. She describes waking up from dreams feeling that she could not breathe. Otherwise, she sleeps reasonably well at night. She describes snoring, but others do not describe pauses in breathing. She describes some difficulty staying awake in the afternoon, but denies drowsy driving. She denies history of TMJ dysfunction, rhinitis, tonsillectomy, or leg movements during sleep.
In terms of this presentation, the things that come to mind are many of our patients actually describe a sleep window like this, where they'll get into bed at 10 or 11, they'll get out of bed around 5:30 or 6, and when we get a little bit more detail, it turns out they're sleeping 6 or 7 hours a night. I think there's actually reasonably compelling data that inadequate sleep contributes to weight gain. And I'll talk to patients about the idea that getting enough sleep at night can help with weight loss. We know that it's easier said than done to give oneself a full 8 hours of sleep opportunity, but we want people at least to do a trial. We want people to try this for 2 weeks and see if they feel better, see if they feel more rested during the day, see if their cognition's a little bit sharper. Otherwise, I think, looking back here, one thing that's important for us to ask is, is snoring worse when patients are on their back? Sleep studies are helpful, but they're not perfect. They represent one night and not every night. And so in every history, now that we've had some experience with positional therapy, we actually try to get some sense of whether sleep apnea is positional. A lot of patients will also describe to us, when I'm on my back, I feel like I have trouble breathing. And it turns out, I think that that's a relatively accurate indicator of sleep apnea, in particular, positional sleep apnea. If the patient says, I turn to my side and then, I feel like I can breathe more easily. We ask about TMJ in a standard fashion because if there is arthritis in the temporomandibular joint, then an oral appliance may be somewhat more hazardous. It doesn't always prevent us from pursuing an oral appliance, but it certainly gives us pause. Rhinitis or any form of nasal congestion can interfere with use of CPAP, so we will often use nasal steroids to improve nasal patency if patients have rhinitis. We want to know whether patients have had upper airway surgeries or evidence of periodic limb movements.
On exam, she has a past medical history of glaucoma, no history of hypertension, type 2 diabetes, or high cholesterol. Her family history showed her mother with a history of a heart attack at 55, and she is a non-smoker.
So here, as we're trying to think about, how aggressively we want to treat sleep apnea, we want to get some sense of what risk factors the patient otherwise has for cardiovascular disease. The more sort of other risk factors the patient has for cardiovascular disease, the higher their absolute risk of a heart attack or stroke, and potentially the more benefit we get from treating sleep apnea, and potentially the more mild a case of sleep apnea we'd consider treating. Glaucoma also correlates with sleep apnea. There's some data that treatment of sleep apnea may improve glaucoma. We receive a few referrals from ophthalmologists with patients who have glaucoma or otherwise. There's something called the floppy eyelid syndrome, kind of drooping of an eyelid, that seems to be associated with sleep apnea, and for reasons we don't fully understand, may be a sign of sleep apnea. And in this case, the patient also has a family history of cardiovascular disease.
On exam, she's 64 inches tall, she weighs 142 pounds, and her BMI is 24.4. On exam, modified Mallampati 3, trace tonsils, and mildly rethornachic.
So I think what's interesting about this particular patient is that this is not an obese patient. Her BMI is 24. And again, so this patient has gone through menopause. Once women go through menopause, the risk of sleep apnea increases significantly. And these relatively low BMI patients who turn out to have sleep apnea often turn out to have positional sleep apnea. Retronathia is also a risk factor for positional sleep apnea. So even as we're kind of starting to look at this patient, we're seeing a couple clues that her sleep apnea is more likely to be positional than that of at least some other patients whom we see. So here's the sleep study of this patient. You can see in kind of the oximetry here that there is some oscillation of oxygen at different times in the night. The reason that oxygen is oscillating at these particular times is that the airway is either completely closing, OA stands for obstructive sleep apnea, or narrowing to an extent that blood oxygen drops at least 3%. This stands for hypopnea. And when you can correlate kind of these dips in oxygen with these respiratory events with S, which stands for the supine position. So R is a patient sleeping on his or her right side, S is supine, sleeping on the back, R right, L left. And again, there's some fairly clear positionality here. And this is something that once you're looking at sleep studies over time, pops out pretty quickly. And again, the caution is that this is one night. There's some variation from night to night. But one thing I really like about this particular study is we don't just see like half the night, the patient's on her back the first half of the night, and then she switches to our left side, the second half, there's a lot of back and forth here. And with each transition, there's really a drop off in airway obstruction. So we can see, airway obstruction, transition, no airway obstruction, transition and position, no airway obstruction. So I look at this study, and this is actually a pretty compelling case for positional sleep apnea.
This patient tried positive airway pressure in the past. She struggled despite trials of multiple masks. We selected the NightBalance. She continues to use routinely with benefit to wakefulness.
Liz and I put a good deal of thought into helping patients with mask fit. This is a skill that Elizabeth has developed over time, kind of working with patients, and figuring out, whether they'll use a nasal pillow style mask or a full face mask or a mask that kind of fits over the nose or under the nose. There are a lot of kind of mask types now, and really the only way to know if a patient's going to respond to a particular mask is to have the patient try on the mask, which takes time. One of the challenges of CPAP, certainly in this country and kind of our current environment, is that in most cases, it's really in most cases, in most practices, it's just the DME company kind of sending masks to the patient. Maybe, a patient calls and says, this isn't working. The DME company says, either we can't send you another mask because insurance won't let us send you another mask, or they'll just mail them a different mask, and that mask may or may not work. I think this is part of the reason, why CPAP compliance in this country is fairly low. It's 50 to 60% of people who end up using CPAP routinely after 3 or 4 months. I think that in a properly functioning sleep practice, that number should be significantly higher.
So our second case study is a 44-year-old male presented with a chief complaint of snoring, typically entering bed between 9:30 and 10:30 p.m. and exiting bed at 7:30 a.m. He awakens once to urinate at night and falls back asleep. Partner elbows him to turn when snoring. He describes sleepiness when inactive, clearly sleepier than 10 years ago on a similar schedule. He denies drowsy driving. Epworth was mildly elevated at 11.
What I like about this case is, we have a patient we have a patient who has adequate sleep opportunity, and despite adequate sleep opportunity, seems fairly sleepy. We've asked about the sleep opportunity. We've established the sleepiness. The Epworth score alone is not a perfect indicator of sleepiness, but it's reasonably good. And I like the approach where we kind of say, are you sleepier than you were 10 years ago? Becoming sleepier is not a natural part of aging. There have been a couple studies looking at, are healthy 75-year-olds sleepier than healthy 35-year-olds? Are healthy 35-year-olds more resilient to sleep deprivation than healthy 75-year-olds? And it turns out that the 75-year-olds do just as well as the 35-year-olds in most measures here. People get sleepier as they age, either if they're on a whole bunch of medications that cause sleepiness, or if they have or if they have specific sleep disorders. And so if a patient is getting sleepier over time, it is a red flag to me that if I can't explain that with medication or change in circumstance or reduction of sleep opportunity, I do have a high suspicion of some form of a sleep disorder. Also here, we have a partner elbowing the patient, and often, we'll hear a story that a partner elbows the patient and says, turn over. And that too is a good marker of positional sleep apnea. If a patient notices that snoring is dramatically different in one position versus another, if a partner notices that snoring is dramatically different in one position versus another, it is a check in the column of likely positional obstructive sleep apnea.
On exam, 70 inches tall, 240 pounds, and a BMI of 34.4, modified Mallampati 3, airway, tonsils 1+, neck 17.5.
So this is a more typical looking patient, a patient that many people would look at and say, here's someone who's at risk of sleep apnea. He's obese and he has a fairly thick neck. 17.5 inches is certainly thick enough to increase risk of sleep apnea. In terms of his original study, again, we can see kind of a little bit of oscillation of oxygen. I'm not sure if that's clearly visible on your screen, but oscillation of oxygen, some obstructive apneas, frequent hypopneas occurring more frequently in the supine position with several transitions, supine left, left, supine right. This patient has some events occurring in the non-supine position, but I'm okay with that. Even if a patient has a few residual events, we can still treat sleep apnea effectively and make a dramatic difference. So here, when we did an in-lab study, this patient had an overall AHI of 41, a supine AHI of 57, and a non-supine AHI of 7. There was a significant difference you can see in supine versus non-supine AHI. I think the interesting things here are twofold. So one, even with positive airway pressure after 6 weeks of use, so this patient had an in-lab study with positive airway pressure in place and still had 15 events per hour, mainly central. So patients respond well to positive airway pressure, but when we look in a careful way, we don't always see that sleep apnea completely resolves. Even these central events are more common in the supine position. In general, not only is obstructive sleep apnea more common in the supine position, but central sleep apnea tends to be somewhat more common in the supine position as well. In our polysomnogram with NightBalance in place, again, after 6 weeks of NightBalance use, we saw an overall AHI of 17. There was no supine time. So of course the non-supine AHI was 14. So overall AHI of 14, non-supine AHI of 14, and you could ask the question, wait a second, this patient only had 7 events at baseline and 14 events per hour of sleep with NightBalance in place when the patient was not on his back. And I answer this by saying there is always some night-to-night variability in sleep studies, in sleep. It's something I think we have to appreciate when we're treating patients, and I think this is part of the reason why physical exam and history and pretest probability are important in making treatment decisions. The one sleep study itself is never perfect. It is one tool among several that we have to assess sleep apnea. This patient elected the NightBalance for comfort and continues to use the NightBalance device. His partner has reported dramatic improvement in his snoring. In terms of some cautions, and we'll circle back to these later, but if patients have a lot of back and neck arthritis, they may struggle to avoid the supine position. Sometimes the supine position can provide some relief with significant arthritis. If a patient specifically says that he or she has trouble sleeping in non-supine positions, I would be somewhat cautious about using positional therapy. BMI greater than 40, very obese, a little less likely to respond to positional therapy. But if you hear if you hear things in history and see things on study that confirm positional sleep apnea, I would certainly consider a positional device. If a patient is adherent to CPAP and reasonably comfortable, I will rarely change treatment. CPAP can be very effective for people, and even if people say, CPAP, the CPAP is, I don't like cleaning it, it's kind of burdensome, I'll have kind of an honest discussion and say, if you can use CPAP all night, every night, that's certainly not everyone, but in that particular patient, I'm reluctant to make a significant change. So where does positional therapy fit? I think a standard sleep history can include questions about position and breathing during sleep. Sleep study interpretation can describe whether sleep apnea is positional. Positional therapy is a reasonable first or second line treatment for positional sleep apnea. NightBalance is the only positional device supported by a head-to-head randomized trial against AutoPAP. When I talk to patients, I'll give them a menu of options, but I will say that positional therapy is quite a non-invasive approach. There's very little risk to it. In terms of NightBalance specifically, we'll talk more about this going forward. But we have found that it's a fairly easy thing for patients to use in terms of putting the device on their bodies. And the NightBalance device, since the trial, has actually evolved in a very positive way in that it can now be yoked to a smartphone as a Bluetooth device. And both we and patients can see how patients are doing. So this is the screen that providers see. This is actually a screen from me trialing the NightBalance device over a week or so, and using it most, but not all nights, I will say. So you can look kind of night by night and see what position, how many sort of hours patients use the device for and what position of sleep they spent supine. And this is kind of what patients see on their smartphones, the number of hours supine, the number of hours of usage, and the percent of time on their back to which NightBalance responded with vibration. So at this point, I'm going to turn the presentation over to my colleague, Elizabeth. Thank you.
Thank you, Dr. Abeluk. So I will be talking about managing the POSA patient after prescribing the NightBalance device. So we typically use the following workflow in our office when we're working with patients. Typically, in the first visit, we review the sleep study results. We review all treatment options for sleep apnea, and if patients are a candidate for the NightBalance device and we determine it's an appropriate treatment, we typically will offer them a demo of the device for 3 weeks. Alternatively, Philips does offer a 30-day money-back guarantee, so there is that opportunity for patients to trial the device at home for a significant amount of time to assess benefit. At the second visit, this can either be done in the office or over the phone. We typically review data and speak with the patient regarding effectiveness of the device. After patients have used the device for 3 weeks or so, they might describe discomfort, shoulder discomfort, hip discomfort that may make positional, the NightBalance device more difficult to use long term. If we elect the device as treatment, the patient simply just logs on to the health store website through Philips and orders the device. Philips then contacts us, the provider, to sign off on a prescription. At visit 3, this is typically 3 to 4 months after the patient has been using the device. We review the data and subjective benefit that the patient is reporting and consider if repeat testing is needed. Often we will troubleshoot issues at that time. We will later in this presentation review some frequently asked questions that I get from patients. And finally, if patients are doing well on the NightBalance device, we typically just see them annually to assess benefit.
I think that as we've used positional therapy and as we've kind of appreciated that there is some night-to-night variability, we will typically do some form of a sleep study, generally a home sleep test, with the NightBalance device in place.
So I think it's important to educate patients on what they should expect when they're using the NightBalance device. NightBalance does have this adaptation program built into the device to slowly train patients to respond to the vibrations during sleep. So I think the most important thing to stress is that no vibrations are actually given during the first 2 nights of therapy. I'm sure several patients will call and say, I laid on my back for 2 hours and nothing happened. So I would make sure you enforce that. Finally, there's a buildup phase where NightBalance then starts to deliver vibrations during nights 3 to 9. The vibrations slowly build up gradually as patients are laying on their back, allowing them to get used to therapy. Also note that the NightBalance allows patients about 15 minutes to fall asleep once the device is switched on. So if patients prefer to fall asleep on their back, they do have that option as well. And then finally, these are some frequently asked questions we get in the office with patients. In the sleep world, we have some tendency to always ask questions regarding maintenance and resupply. So the NightBalance device, there are some pieces that need to be maintained. The sensor device, docking station, and travel case all need to be replaced every 3 years, and the chest strap needs to be replaced annually. Patients also ask about how to pause the vibration on the device. All they have to do is get up or sit up in the middle of the night, and this will stop the vibrations for about 5 minutes. Patients are also able to sleep on their stomach. To confirm correct placement of the device, patients should simply just wear the device in the center of their chest, and the display should be facing away from their body. People also ask how often they should charge the device. I recommend they charge every other day for optimal performance. And finally, most of our patients are engaged and want to have access to their data. Simply, they just download the app on their smartphone, and the app will prompt them to follow directions to link to the portal. And that concludes both my and Dr. Abeluk's presentation. We look forward to questions. I'd like to turn over to our moderator, Steve.
Thank you both, Dr. Abeluk and Ms. King, for a very informative and professional presentation. It was very enjoyable. Thank you. Before we move on to those questions, I would like to remind people how to obtain their CE credits for attending. So this session is approved for 1 contact hour of continuing education for physicians, nurses, and respiratory therapists, which can be obtained by going to saxtesting.com/BO. You will need to register at the site and complete the evaluation. Upon successful completion, you will then be able to print your certificate of completion. Our support for this educational activity is provided by Philips Respironics. Dr. Abeluk and Ms. King, your presentations bring up several interesting questions, and we have a few minutes left to run through some of them. So I'd like to pose the first question to yourself, Dr. Abeluk. Dr. Abeluk, how do you, you mentioned this within the context of the case studies that you did, but if you could summarize for us how you decide when to use a positional therapy device as a first and second line therapy.
Sure, Steve. So the study showed that the NightBalance device is not inferior to CPAP, and we saw it work in a lot of patients. For many patients, if I'm convinced that patients have positional sleep apnea, I'll give them kind of a menu of options, and I'll be open to them either using CPAP or positional therapy, depending on their preference. I think the exception here is patients who already have a diagnosis of atrial fibrillation or heart failure, or who have some sort of underlying medical illness where there's compelling data for CPAP specifically. In those cases, I would favor the NightBalance device as second line treatment.
Thank you, Dr. Abeluk. Very informative answer. My second question I'm going to pose to Ms. King. Ms. King, how long does it take, in your opinion, before a patient becomes stable on a positional therapy device like the NightBalance? And how do you objectively judge this as part of your follow-up algorithm?
So that's a good question. Typically, we see patients 3 to 4 months after they've been on the NightBalance device. We definitely use the data available online on the portal to confirm that there is minimal supine sleep occurring at night. Often patients will describe feeling more wakeful during the day, improved sleep quality, less snoring at night reported by bed partners. And finally, we will at times repeat testing with the NightBalance in place to confirm that sleep apnea has been fully treated with the device.
So as a follow-on to that, is that the time point at which you would consider introducing NightBalance as a second-line therapy? Or would maybe you consider doing that earlier under some circumstances? And that's a question for both of you.
So I think that since NightBalance is kind of a newer treatment, I would say that most of our patients, when we see a significant amount of sleep apnea, even those who have positional sleep apnea, either have been using CPAP or have some familiarity with CPAP. I would still say in our practice, the majority of patients kind of start with CPAP, and of course, like some people do well and some people struggle. And I think that, part of the model for kind of any sleep practice, I think, is, we need to be sort of aggressive about following up patients, and we need to be aggressive not just in kind of doing studies and doing procedures, but in actually seeing whether our interventions are effective, asking patients kind of what their experiences are, and if patients, are struggling, then sort of considering something else. And I think, frankly, it's important to kind of set up expectations at first that, CPAP's hard. Many people, we talk to patients about sort of what the pros and cons are and how people kind of adjust to it. But we want people to come back even if they're struggling with their initial treatment. And I think that we want to, a lot of times, if patients are struggling with their initial treatment, they don't know anything else. They often, they've often kind of had enough, and they may not want to come back to a sleep specialist. It feels to them like something that's kind of elective. And so I think part of being successful with a treatment like this is having patients come back if they're struggling with a first-line treatment.
And do you use the device data from both the PAP devices and the NightBalance device to help you judge this? I know that adherence is obviously one important metric, but are there other metrics from those therapy devices that you can obtain that sort of point to whether someone is doing well or not so well?
So, if we see any data suggesting that a patient's spending a lot of time on his or her back with the NightBalance device, then that's sort of a relative negative. I think that most of our data, not only with NightBalance but with CPAP as well, comes from the patient's experience, and comes from kind of questions about the patient's symptoms, as opposed to kind of numbers that for instance, a CPAP device generates for us.
Great answer. Thank you, Dr. Avila. We've got a few more minutes to go, so we'll try just a few more questions. Now, Dr. Avila, you stated earlier that the study data has shown that the NightBalance device is considered by patients to be more comfortable, easier to use, and easier to adjust to than CPAP by patients. Do you see this translating into improved adherence and outcomes in routine clinical practice? I know it did in the positive study that you participated in, but in clinical practice, are you seeing the same thing happening?
I think in clinical practice, there's a process where we're still learning kind of where NightBalance and positional therapy fits into sleep medicine. I do think that adherence to NightBalance is very good. I think we're still learning about outcomes. I would say that we learned yesterday that Medicare was convinced enough by this study that they kind of sent out an early indication that Medicare CMS may come to cover the NightBalance device at some point soon. And so we're excited about that. And I think it validates kind of what we've seen about this device, and what we've seen in research patients, and I think and now much more recently in some of our clinical patients.
Yeah, that was certainly good news we received. We just have one more minute to go, so we're going to go for one final question. Dr. Avila, do you see potential to use the NightBalance device in combination with other sleep therapy modalities available, such as an oral appliance or a PAP device? And in what circumstances might you consider doing so?
I think it's an interesting question. Whenever we have a patient with an oral appliance, we'll do a study. We'll see what breathing looks like with the oral appliance. I think especially with an oral appliance, there's potential to kind of use this device in combination. I think with neurostimulator therapy, with neurostimulator therapy, if we see an incomplete response, we'll take a look at the data, see if there's kind of an element of positional sleep apnea remaining, and in a case like that, I'd consider adding positional treatment. Sometimes patients will lose a significant amount of weight, And at that point, we'll see, some residual positional sleep apnea, and then we'll potentially be able to use the NightBalance device to kind of eliminate that last bit of sleep apnea remaining.
Excellent answer. Thank you, Dr. Abeluk. Well, that's all we have time for. So I'd like to thank you both for participating today. I think that was an excellent webinar and very, very professionally delivered. Thank you very much. At this time, I'd like to turn the presentation back to Tracy for final comments. Thank you both, and speak to you soon.
And on behalf of Saks Healthcare Communications and Philips Respironics, I would like to thank our speakers today, as well as to our audience. We hope you have a great rest of your day, and this concludes the event. Thank you.